I'm Paul Adler. I'm a community optometrist, have 2 private practices, and I sort of specialise in binocular vision problems. My practice has around 30 or 40 patients a week where we teach them eye exercises, and so binocular vision is kind of our passion really. I'm hoping today to explain to you that I don't really think binocular vision problems in practice is nearly as difficult as many practitioners believe, and I'm hoping to take you through a sequence of demonstrations and information that will allow you to be more confident in practice in due course. It's obvious when you first start doing binocular vision, if you haven't done much before, take on the nice easy cases, ignore the complicated ones, and as your confidence grows and your success grows, because it surely will, then you can take on more complex cases and you can feel much happier in doing so. The obvious one to tell you about is the cover test. It's essential. You can't do a routine assessment in my view without doing a good cover test. It's the only test that will allow us to tell the difference between aphoria and atropia, and to that end it's really important to do it accurately. So if we move on to motilities, the best way of doing it is probably to use a focused pen torch placed at 50 centimetres, although this can get a little bit tricky if you're trying to do a cover test, which you should be doing in all 9 cardinal points of gaze. Make sure that you don't move your pen torch too far to the periphery. If you do, you're bound to find some incompetencies that you don't want to see. So I'd like to move on to measuring accommodation. Accommodation is often neglected, and orthoptists very frequently don't measure accommodation, which always surprises me. But actually it's really quite important because you don't converge and accommodate separately, and the two are completely linked. And even children, in fact particularly children, have some significant problems with accommodation quite often. So I would always advise that you measure the near point of accommodation monocularly, measuring at least 3 times because you expect the patient not to fatigue, and you'll be surprised when you do that how frequently patients with symptoms increase their near point of accommodation, and their near points recede after just 1 or 2 attempts at measuring it. It's really good to compare the 2 eyes together, and we know that if there is more than 2 prism diopter difference between the 2 eyes, then it's worth treating those patients. If you can imagine the reason why, there's a single feed in terms of the neurological feed to both eyes in terms of accommodation. So if one eye is under accommodating compared to the other, there is always going to be a blur on the under accommodating eye. That's going to degrade stereopsis. And if the patient becomes aware of a slight blur, they may institute excessive accommodation to try and fix it. Of course, they'll never succeed because the under accommodating eye will now actually be accommodating accurately, but the other one will also be over accommodating, and that will cause blur, and that often leads the patient to relaxing the accommodation to try and find a point that is clear. They will then institute and relax, stimulate and relax, and that can lead to binocular instability. So treating the difference between the 2 is actually really quite good and works really well. When you're assessing accommodation, use an N5 print, unless of course the patient can't quite manage that, in which case you should use something that they can clearly see. Remember to reiterate what it is that you're after. It's really clear, not nearly clear, and it's not just about readable, it's, as I say, really clear, and it needs to be sustained blur. So it's okay if it goes blurred a split second, but if it's sustained as blurry, that's not so good. And then bring the target, whatever you've chosen, towards the patient slowly. I like to sort of just briefly pause every few centimetres to give the patient, particularly young patients, thinking time. They're not very good at giving you feedback. And if you watch carefully what's going on underneath your cover, you can actually see quite interesting responses. So using the opaque cover helps you understand what's going on. So assuming that the fixing eye is pointing at the target and accommodating accurately, the first thing that you'll observe, and you'll know from everyday experience anyway, that the eye underneath the cover has to converge to the same point if the binocular vision is normal because of accommodative convergence. So carefully watching the eye underneath the cover, as well as the eye that you're working with, you'll notice that if the eye under cover stops converging, then de facto the fixing eye has to have stopped increasing its level of accommodation. If at that point the patient's eye under the cover goes whizzing out, then it's pretty well likely that the eye that you're testing the accommodation on has not only stopped increasing its accommodation, but the patient's given up bothering and has released that accommodation. If, on the other hand, the eye under the cover goes whizzing in, and they do sometimes, it's pretty sure that not only has the patient found it's difficult to maintain accommodation, but they've put in a huge amount of effort to do so, and they've gone into accommodative spasm or accommodative excess. And those are the patients you need to be very careful with, because if you don't detect that, then it's quite possible that you'll give a plus lens because you'll think the patient's blurring at 30 centimetres, when actually they've gone into accommodative excess, and that lens will then cause you grief and the patient won't be comfortable with it. In fact, when you're measuring near points of accommodation, it's really good practice, once the patient's reported first blur, to move the target closer and ask the patient to tell you if it becomes clear again. If it does, you have a sure way of telling that that patient is in accommodative excess, and that's really useful. And another test that you can use to prove that is near point retinoscopy, well worthwhile doing so, and measuring accommodative facility, because the patient who goes into accommodative excess will find it difficult, most likely, to relax the plus lens, and we'll talk about facility in just a few minutes. Now, whilst you're measuring near points of accommodation, it's really useful to look at the pupil of the eye that's doing the accommodating. We know that as you accommodate, the pupil will myose slightly. So as soon as you're noticing that the pupil is no longer getting smaller, you have a pretty good idea that that patient's about to tell you it's all gone blurry. And you can have a second objective method that indicates the patient's got poor accommodation. And one of the criticisms of measuring near points of accommodation in patients is that it's a very subjective technique, but actually it doesn't need to be if you look at the eye under the cover and the pupil. If you're working with a patient and you suddenly find that the pupil dilates, you know very well that they can't be still attending and accommodating at that point, so you know that you can predict it. Equally, if the pupil becomes suddenly very small, you know that that patient must have gone into accommodative excess or spasm. And remember, the difference between those two is quite important. Accommodative excess just means too much, and accommodative spasm is an uncontrolled excess causing pain. So most patients who have been described as being in spasm probably aren't. They're usually in excess. So what's normal for accommodation? Well, all of us will have remembered Hofstadter's formula. It was published in 1944, and it was based on just 35 patients, which is a bit scary by modern standards. But he produced a rule of thumb which still holds reasonably well true today, that the minimum amplitude of accommodation should be 15 less 1/4 of the patient's age in years, and that is different to the expected amplitude of accommodation, which should be 18 less 1/3 of the patient's age in years. So you have a quick way of working out what you expect the patient to be. There's lots of work done that gives you information. You can pick some information up in terms of instantly know what the expected norms are from your RAF rule. And you can look at work by Donders and Morgan that gives expected norms, but there's been very little work done on children. In fact, normal near points of accommodation in children hasn't been tested in real children, except for one study that we found with only 25 patients, and that wasn't particularly good. So recently we did some work with the help of Brendan Barrett and statistician Andy Scally at Bradford University, and we took a group of children and measured their amplitudes of accommodation, and their near points of accommodation. We took about 137 children with an average age of about 8, and what we discovered was quite surprising, is that the median amplitude of accommodation, and these were unselected children, we just took them if they were spectacle wearers, we didn't refract them, or spectacle wearers or non-spectacle wearers, we didn't refract them, we just took them, so we had a kind of a general unselected population of children. And we discovered that the median age was, the median near points of accommodation or amplitudes was 19 diopters. What was curious was that there was quite a lot of variation between the children, but not so much as we could expect from the testers. And we managed to tease out how accurate the examiners were. And we had 5 trained assistants who helped us with these hundreds of measurements. And we discovered that the within subject variation, which took account of the tester, was a huge 5.2 diopters. So it's very important that you get very consistent in the way that you measure amplitudes of accommodation, because obviously that's a huge variation, and particularly in a low accommodative or patient with low accommodation, that's bad news if the accommodation is low, and the error rate could be up to 5 diopters. So be very careful when you measure it. In fact, we discovered that between 75 and 79% of the children that we saw had monocular amplitudes of accommodation of greater than 12 diopters when we tested them initially. And we did retest reliability studies on this group. And what was interesting is that if you retested them twice more, pretty well 90% of the patients would have or did have amplitudes of accommodation that measured over 12. We worked out that actually if the patient had amplitudes of accommodation of better than 12 initially, that they very rarely improved. If the patients, however, had poorer accommodation than 10 diopters, then those patients were unlikely to improve on repeat testing. And for those patients who initially showed 10 to 12 diopters of accommodation, those patients needed to be treated with some caution. And you may find that in that group there'll be some normal ones. So I think the guidance is that you can assume any child who has accommodative amplitudes of less than 12 diopters is pretty abnormal. We also calculated from the figures what the prevalence in that population was of accommodative dysfunction, something that doesn't appear in the literature, and nobody's really made an accurate assessment. But remember, this is just a small sample, but nevertheless we think that monocularly anything between 4 and 6.5% of the patients in any one group could have an accommodative dysfunction. And when you measure it binocularly, you may miss a few of the monocular problems, and around about 3% of the patients have a problem. So a few tips that you might want to know about when you're dealing with accommodative problems. Don't give plus lenses at near in children if they have accommodative excesses. As I mentioned before, the chances are that they'll go wrong. They'll reject the lenses and it will make them more blurry. Do use near point retinoscopy. It's a fantastically easy technique once you've got the hang of it. It's well worth thinking about doing, and is worth measuring accommodative facility to help with your diagnosis if you're not sure what's going on. So what's accommodative facility? It's simply a method to find out how well the patient uses their accommodation. Traditionally, we've just measured near points of accommodation, but it hasn't really told us how well the patients can release accommodation. And all of us, when we're looking at the dashboard of our car and then looking down the road at the signs, or if you're working at school looking from your textbook back to the board, you need to be able to swiftly change from one to the other. So the standard test is usually using a set of lenses which have like a confirmation test really. So on a stick you would have 2 pairs of lenses. On one side you'd have a pair of -2 lenses, and on the other a pair of +2. When you first test it, you need to do this in good light. You would do it monocularly, and you'd ask the patient to tell you when an N5 print or N5 text is completely clear. And as soon as the patient can do that through their -2 lenses, you know that they've stimulated to more diopters of accommodation. Flip it over, ask them to look through the +2 lens, and they will then being asked to release the 2 diopters from the -2 plus another 2. So it's very important that you do this at no greater than 40 centimeters, otherwise the patient will not be able to make the text clear. And that's actually very, very important. And then you record how many times the patient can flip between a -2 and a +2, making it clear in 1 minute. The easiest way to do it is just to count the number of lenses they appear to be looking through and divide it by 2. This is then repeated with both eyes working together. And remember, when you're asking a patient to stimulate 2 diopters of accommodation, they will have to converge because of the accommodative convergence. So binocular flipper testing is much more complicated, and the patient will then have to pull their eyes back outwards to maintain clear single vision. So you always expect the results to be slightly less, and it's very important to know that if a patient is cheating, which they can do by suppressing, even though possibly not on purpose, then the results will be at least as quick as one of the monocular results, on probably the best monocular result that you recorded earlier. So you can compare the difference between the monocular results and the binocular results to get an understanding of what's going on. Of course, if you've got a patient that can't manage to stimulate 2 diopters of accommodation, you know that they have an insufficiency and they're unable to stimulate accommodation. But if they can't relax and see through a +2 lens, that's suggestive that they're over-accommodating and cannot relax any of their accommodation, assuming you've got the refraction right, of course. And you need to rule out latent hyperopia. This technique is often used for treatment, giving the patients lots and lots of practice. And it is often described in the text as accommodative rock. One important point is that it's worth using a red-green bar reader to test binocularly to make sure that your patient is not suppressing. And you can see one of those being used in the video clip at the moment. The normal values vary very much. Young children have very poor standard deviations or very high standard deviations, and you can't really necessarily rely on them. But for people from 13 to 30, and quite often younger, the normal values are usually expected to be at least 12 cycles per minute on each eye. And if you've trained them very well, they can get up to about 20, maybe 22, and they can be really quite slick indeed. And remember, the speed and performance should be equal in both eyes. If you treat patients for accommodative disorders, the literature suggests that it's extremely effective, giving about 95 to 97% success rates. And it's actually really quite easy to do. You can use a technique called trombone reading, where you just simply ask the patient to read text that's quite close to their threshold and bring it towards them slowly whilst they read it. So you ask them to do that themselves. You can hear that they are no longer coping very well because their voice becomes less and less confident and they get stuck. And it's very similar to the way that I test for near points of accommodation, bringing it closer and then coming back again. Remember, it's not just stimulating accommodation that you want the patient to be good at. You want the patient to be able to release accommodation properly as well. And so that's something that you should also test for as part of your near point accommodation routine. As I've said, you can use the accommodative rock flippers as a technique and send them home with the patient. And you can get the patient to concentrate on far objects and refocus to near, initially starting with monocular skills. Always treat accommodation monocularly to begin with before you put the 2 eyes together and complicate things by making the convergence and divergence work at the same time and the same positions as the accommodation. So that really brings us nicely on to looking at convergence. And convergence anomalies include more than just measuring near points of convergence. Remember, there's quite a few that you could consider and need to detect. So you've got convergence weakness exophoria, which is often termed in Europe as decompensated exophoria. That's quite different to convergence insufficiency, which is due to problems of the convergence reflex, really. There's convergence excess esophoria, which is too much convergence. So that's just as debilitating to the patient as not enough convergence. And the divergence excess exotropia, which is something we've mentioned already, causes a small exophoria, but normally it's much smaller and patients cope with it reasonably well at near, but there are divergence in the distance. Often patients learn to suppress and are asymptomatic, and those are much more difficult to treat, and if you're just beginning, don't bother. And then finally, divergence insufficiency, which is a large esophoria at distance and a normal heterophoria at near. Again, helping those patients can be a bit more challenging. So, near points of convergence, there used to be quite a lot of debate going on about whether you should use a so-called accommodative target or pencil point or pen point, and you'll notice that I've reverted to the most convenient method, which is using a pencil point. And that's because there are several studies that show that it's just as good and it works well. In a study that I was involved with using an RAF rule to measure convergence, if you decide to measure convergence in the RAF rule using a vertical line target, which some people feel is a good way, we found that you'll overdiagnose convergence insufficiency by about 1.9 times, so in almost twice as many cases. And the reason is not altogether obvious, but it's worth measuring in free space and abandoning your RAF rule for measuring convergence. So the assessment of convergence near point is not just for how close can the patient get, it's how comfortable the patient gets, and blur points are actually much more important in many ways than break points, and recovery points are also extremely important. But you should be looking out for any time where the eyes don't seem to be properly fixating, and that will give you an indication that that patient ought to be experiencing, if nothing else, slight blur and the early signs of diplopia. So as you do the test, bring the near target, whichever one you decide to use, from about 50 centimeters and bring it closer slowly. If you do it too fast, you don't give the patient enough thinking time, and the patient doesn't really remember or appreciate the subtleties. You must go quite slowly, and it's actually much more difficult for the patient as well, so you're more likely to find an issue. The eyes should, as you know, turn symmetrically inwards as you bring the pen closer to your patient's face, and the pupils, just in the same way as in measuring accommodation, and for the same reason, because the patient is accommodating, should constrict smoothly. And you get to look for how smooth it is, how easy it is for the patient to do the task, what symmetry is like, whether there's any loss of fixation, and also watch the patient's face for any signs of discomfort, watery eyes, or any kind of turns as they're doing the test, which will give you an indication that they're managing to do the test, but the cost to them in terms of effort has become extremely difficult. And record how intermittent or otherwise the loss of fixation is, which eye loses fixation, because if the patient doesn't report diplopia or blur, then you know for sure that they must be suppressing, and which way it's gone, inwards or outwards, because obviously you'll understand whether they've got better when you retest them in the future. And look out for those patients that make small inward movements followed by divergent movements and inward movements. Those patients are clearly struggling and are likely to have binocular instability, which in my way of thinking is probably more debilitating than just having a stable angle squint, because it causes intermittent blurred and double vision, which is hard to deal with. The objective near point of convergence is the point at which you observe as a practitioner when fixation is lost, and that should be compared to the subjective near point, which is the point at which the patient says he's lost. The difference between those two is suggestive of suppression, and as the patient comes closer, you would normally expect somebody who's not suppressing to instantly be able to tell you that the target has become blurred or double. And surprisingly, quite a lot of patients don't seem to be aware that they're getting diplopia, but they still seem to be able to maintain their attention on the task. As in accommodation, repeat the measures at least 3 times. The normal patients will either stay the same or get better each time you test them, as you'd expect with practice, but the bad ones can rapidly deteriorate, and you could be surprised that 3, 4, 5, maybe 6 attempts will lead them to go from a near point of convergence from what's reasonable at 8 centimetres, perhaps 6 centimetres, right out to 15 or 20. And those patients are clearly not going to be able to sustain their convergence over a long period of time, and they're going to be the ones that lose attention and concentration when they're working or at school. As I mentioned before, the recovery rate should be completely normal and perfectly binocular by 12 centimetres. So if their patient doesn't recover convergence by 12 centimetres, then that is as much a problem as a patient who can't converge to 12 centimetres and needs to be looked at in more detail. I often use near point of accommodation measurements and record them in centimetres, because it's really useful to compare the patient's performance in centimetres with their convergence. So if you've got a patient that has great accommodation to say 10 centimetres or 6 centimetres, but that patient can't converge any closer without blur than 16, you know that the accommodative system is working okay and that this must be a convergence problem. Equally, if you have a patient that converges to 6 centimetres but has poor amplitudes of accommodation and can't manage near points of closer than 20, you know that it's not a convergence problem but an accommodation problem, and those patients are very often missed in practice because we just assume the accommodation must be okay, and I'm afraid to say it more often than not isn't. There is a group of patients who have both accommodation and convergence problems, so it does get a bit more complicated, but if you treat the accommodation problems first and then the convergence problems, you usually get good results. One test that's actually really worth thinking about if you measure mediocre or poor convergence is to measure jump convergence, which is usually done from around about 20 centimetre target, pen, pencil or whatever you choose, to around about 50, and you ask the patients to shift from one target to the other and observe their performance. And Evans reports that there are 4 different types of responses that you can get that are abnormal. The first of them is the overconvergence, and a patient may go from far object to the near object, overconverge and make a corrective movement, and this isn't considered to be too bad. So this is not something that maybe you would want to treat. You can see versional movements where both eyes make a version to allow the motor dominant eye to fixate, followed by then a convergence to restore binocular vision. You can get slow and sluggish, hesitant eye movements, which when you're looking, just look inefficient. Or you may see no movement in either one or both eyes. And the first of those 4 are considered to be quite normal, but the last 3 are considered to be abnormal. And even in the presence of reasonable near points of convergence, if you have an abnormal jump convergence and symptomatic patients, you should consider treating the patients for convergence problems. We've talked about looking at near points of convergence, but when you do find a mediocre or marginal convergence, one of the things that's worth thinking about is whether or not that individual that you're looking at is able to sustain convergence. And one of the ways that you can elicit whether you feel comfortable with not treating a mild convergence issue is to measure the patient's fusional range or fusional reserves. And to do that, you don't need a prism bar, although you can use a phoropter or refractor head if you want to. In either case, the average change that you should change your prisms by as you go through is about 4 prism diopters per second. So not too slow, but not too fast. This is very good. Well done. Slightly blurry. And when you see 2, definitely tell me. Still dead clear?
It's not dead clear, but I can't see 2.
Still single, I should have said, shouldn't I?
Yeah.
Still single?
Yeah.
Still single?
Yeah.
Pretty well off my scale then, aren't you? Brilliant. Okay, we're going to do the same thing with the other eye now.
Okay.
Okay, this will be hard. So, you ready? So we'll do the base in reserves. This is testing your ability to pull your eyes outwards. Much harder, I think. So as soon as it goes a little bit blurry, tell me. Okay. Can you make it clear? Bit hard. So tell me when it doubles.
Double.
And as soon as it's single and clear again.
It's single and clear.
Excellent. Okay, well done. The only thing that you need to remember is take your prism bar, use a small target, ask your patient to report when things initially go blurred and they can't make it clear, and then when it goes double, but then continue until the patient, or by reducing the prism at that point, until the patient reports it's clear and single. So you would typically do that both for base in, that is with the prism bases towards the nose. By doing that, you're actually effectively making the light move outwards and you're forcing the patients to diverge. And you use base out prism to test convergent or positive fusional range, and there you would increase the prism bit by bit until the patient reports blur or double, and you're measuring the ability of that patient to maintain accommodation on the target that you have set and to converge by a greater and greater degree, dictated of course by the prism. Normal adequate values for prism fusion range are a little bit variable depending on how you measure them and how fast you go and the target, but for base outs, patients should really report blur point when the prism bar is either 16 or greater. So in other words, they shouldn't report blur before 16, and diplopia should not occur until the patient is at least at level 25. And then recovery rates, the recovery rate should be as quick as possible, but no less than 10 prism diopters. And if you're looking at base in reserves, that's actually much lower usually because it's much harder for people to diverge than converge. The blur point should be around about 13, break point should be at 20, and recovery should be around about 10. And after you've done this a few times, it's actually not very difficult, but after you've done it a few times, you'll understand what normal is for normal patients using your technique. And then you should reference your own patients to that technique, and you should try and use the same technique every time you do it so that you've got something accurate that you're comparing to. But common test in orthoptic practice is not so often done in optometry practice. Prism bars are available from quite a number of the manufacturers. They don't cost a huge amount of money, and they can add a huge amount to your management of patients by understanding whether the convergence is normal, not so much normal, but whether the patient can cope or not with the level of convergence that he or she has. And discussing what normal is, there's quite a lot of variance in terms of what we think normal is. It's widely considered to be no greater than 8 centimetres, and there's quite a lot of literature that puts that level out. And recently some groups have shown that for children, particularly 6 centimetres or closer should be the normal levels that you should aspire to. And we know that treatment of convergence insufficiencies is actually really good. In fact, there's a dearth of accurate good random control trials for most orthoptic procedures. Treatment of convergence is actually not one of those. And now there is actually cast iron scientific evidence to suggest that the very best way of treating a convergence insufficiency is by eye exercises. And a paper published by Scheinman in the Cochrane database in 2011 categorically states that regular in-practice or in-office orthoptics treatment or vision therapy is by far the most effective treatment method. The second best treatment method is by computer orthoptics, and they looked at the evidence for a particular method of computer orthoptics by a company called HTS, and that works extremely well. And the least effective is by home exercises. They did some interesting reviews looking at prescribing Prisms for patients with convergence insufficiency, and they concluded in that paper that Prism prescribing was no better for the relief of symptoms than was placebo. So there isn't really much of an excuse to prescribe base-in Prism for patients on a regular basis for long-term relief of convergence insufficiency, certainly up to probably the fourth, maybe the fifth decade of life. There is no reason why patients shouldn't successfully be treated. And in our study that was published in 2002, we showed that you could get successful treatments in between 80 and 98%, depending on what near point of convergent norm you were using. So if you used 10 centimetre as being acceptable, we had 98% of our patients were completely sorted, cured, and if we use 6 centimetres, which is certainly much more challenging for the older children, we managed about 80.3%. So prescribing of Prisms though can be useful, and it can be useful in those patients who are just about to take exams and don't have time to do exercises, and it can be useful for patients who can't start exercises because their convergence is so remote that they can't get going, and sometimes they may be used for a short period of time in order to help for acute sort of episodes. But in general, eye exercises are, I'm afraid, the way to go, and there's ample opportunity for practitioners to help patients. We get very good results, and it's quite easy to do. So whatever your preferred option of treatment, one thing to really emphasize is that if you've got a combination of accommodation and convergence problem, always treat the accommodation first. The reason is dead simple, really, is that if the patient is experiencing blurred vision because of accommodative dysfunction, they're not going to be able to recognize subtle misalignment of the optic axes, which then can simulate blur, and they're not going to be able to do their convergence exercises very well. So actually, treating the accommodation monocularly before you do any binocular work is really good. And a word of caution, it's much better to use stereoscopic, like cat cards or dinosaur cards, or one of the stereoscopic systems which require the patient to maintain accommodation at the plane of the target and pull their eyes in, or in fact outwards if you're treating divergence, than it is to use pencil to nose exercises. Pencil to nose requires a patient to converge but also to accommodate, and actually if the patient relies on accommodative convergence and grows older and is unable to use enough accommodation, then that patient will start to get problems later on in life. So we rather avoid pencil to nose exercises in favour of any other system that requires no accommodation whilst their patient's learning to converge voluntarily, to fuse properly. So how do you do it? We'll always start by demonstrating physiological diplopia to your patients. That's quite clearly essential. All convergence and divergence exercises are based on physiological diplopia methods. And when you are doing any exercise, make sure the patient really can at all times be aware of the physiological diplopia that has to be there. If you don't, you're at risk of teaching your patients to suppress one eye, which doesn't work very, very well. So there are relatively few methods of training. So we've talked a little bit about pencil to nose. There's using stereo cards where the patient actually creates 3D objects, but it isn't really 3D. There are haptoscopic methods, which are methods where the patients have to look through small holes at targets and fuse and either converge or diverge to fuse the targets. Most common are aperture rolls, very common in the States, although quite a few practices in the UK are now using them. And then there are stereograms made of red and blue or red and green images that are slightly different, that you can slide one over the other to improve fusional ranges. They're called tranoglyphs. And there's a group of exercises that are exactly the same using polarized material called vectograms used in a light box that are very interesting and very effective. One of the easiest ways is to use computer orthoptics, as I've mentioned, and they usually use a red-blue or a red-green system for training patients to improve their fusional range and to over-converge or over-diverge relative to accommodation. They're all quite easily available. I haven't mentioned stereopsis, and probably I ought to have done. And actually, stereopsis ought to be measured on all patients that you're considering any binocular vision work, so that you can establish, first of all, that they do have both eyes working and switched on, and that they do have some 3D ability. And you do need to be careful, though. Not all stereo tests are the same, and some are much easier to do without good stereopsis. And you need to remind yourself that probably 2% of those who are binocularly normal cannot do the 3D test, so they're stereo blind. So don't assume that there's no binocular vision because they can't do a Randot or they can't do a Frisbee test. Some criticism of Randot has been made because you, as I say, can see the targets quite easily, certainly the big ones, when you're not even wearing the polarized glasses, and you can make a pretty good guess of it. But if you use any 3D test, particularly Randot, for establishing whether or not your binocular vision work, your vision therapy with your patient has given improvement, be a little careful. And we did a little research on reliability testing on Randot recently, and it established that you needed 3 increments improvement in order to be sure you got a real effect. And there's a huge learning effect on that particular test. So do be aware. Don't assume that you've done great work if you've got a patient from 200 seconds of arc to 100 seconds of arc, which sounds great, but actually you probably need much more than that to be sure that you've got good results. One of the things that I'm often asked is how do I prescribe Prism, and how am I sure it's going to work? Well, actually, I think it's probably fair to say that prescribing Prism is much more of an art form than an exact science. In general, the rule of thumb is to give as little Prism as you possibly can in order to make the patient's problems recompensate and to make the patients comfortable and to resolve the symptoms. But because patients change all the time, it's actually sometimes quite difficult to know exactly what to do and by how much you should correct the patient. Probably the first thing to say is that if you measure any vertical eye muscle difficulties, always fix those first. So if you're going to use Prism, even small amounts of vertical Prism can make a huge difference. And you'll be surprised, or possibly you won't, but when you give a small vertical Prism, if it's necessary, that very often gets rid of any of the horizontal need for Prisms, so or certainly reduces it. So always deal with the verticals first. One of the very popular methods of prescribing Prism, or at least looking at looking at fixation disparity over the years, was the Mallet unit, which was developed in the 60s by Ron Mallet. And that's actually quite interesting because it suggests that patients who show a fixation disparity and needs a Prism to align the little bars are more likely to have symptoms than patients who have no fixation disparity. And for pre-presbyopes, we know that an aligning Prism in the horizontal direction of 1 prism diopter or more, it is quite likely to be associated with symptoms. and for presbyopes, 2 prism diopters. So if you've got a patient who's symptomatic and you're showing some binocular instability and difficulties, and you're getting 1 prism diopter of slip requiring an aligning prism, then it may well be worth prescribing that. But there are 1 or 2 caveats, really. The problem with the mallet unit is it only indicated that correction is required for a small proportion of cases who have significant heterophoria or who are usually symptomatic, and the prescriptions that result are always a bit small. Nevertheless, that these prisms do seem to be quite effective, and you can quite reliably use them, except for on some cases where there's binocular instability, and some cases of exophoria where we've all seen them in practice. On cover tests you see quite a reasonably high or moderate exophoria, and then the patient needs base out prisms at near, and in those cases I think what's happening is that the patient is an exophore, and because you've asked them to do a very specific near task and they want to do well for you in the test, they then use huge amounts of accommodative convergence, so accommodation and convergence, but they're not very good at it and they're not very accurate. So those patients tend to overdo the accommodation because you'll remember that the targets aren't actually that tiny, and they over accommodate and then become esophoric for the duration of your test. And those situations you've got to rely on measuring your fusional ranges and rely on your kind of clinical acumen and intuition probably to make a decision about how to manage that patient. So for that reason, quite a few BV practitioners have kind of gone off measuring every single patient on the mallet unit, and certainly it probably should only be used for symptomatic patients, and it should be used or you should use it for prescribing guidance only when it matches your other findings. Interesting clinical experience suggests that the prism strength doesn't get greater and greater subsequently, and everybody does seem to be worried about if you give prisms it's going to make you worse, and it's going to get worse and worse as you get older. That certainly hasn't been my experience over the years, and I think that does tend to happen when there's grossly abnormal binocular vision possibly, but it doesn't seem to cause a problem for small amounts of prism given to maintain compensation. Interesting, there was one random control study that shows that prisms prescribed with the mallet near vision unit significantly improved the rate of reading when there were 2 prism diopters and more. And some practitioners appear to be giving patients who have reading difficulties a little bit of base in prism without much justification. And on the whole, that may be the case, but if there is any retinal slip and if there is a convergence problem or the fusional ranges are poor, all the evidence suggests that you should be treating that with eye exercises. Nevertheless, this does support previous work that shows that there's a small improvement in binocular visual acuity if you use a mallet prescribed aligning prism. So it does appear to work. The sensitivity and specificity of the mallet unit's quite good. Sensitivity is 75%, specificity 78%. And that's for detecting symptomatic heterophoria in pre-presbyopes. But if you look at those numbers, that means that it's not too sensitive or too accurate on around about a quarter of your patients. So it's not an infallible test, and I would advise caution when you're using it to prescribe prisms. Listen to the patient's symptoms, look at the signs, take your overall measurements, and then make some clinical judgments based on all of it rather than just that one test. There are some other techniques that have been put forward for prescribing prisms if you want something that you can get your head around. But mostly when I mention it, and I'm going to now, people get a little bit stressed because they've heard of these things years ago when they trained. One of them is Sheard's criterion, which is often stated as specifying that the fusional reserve that opposes the heterophoria should be at least twice that of the heterophoria. In fact, whilst that's correct, Sheard had several criteria that he developed, but it's always that twice the Fourier rule that persisted. Before Sheard's criterion came along, there was somebody called Percival who also had some criterion that he developed, and his point was that convergent and divergent fusional ranges should not be disproportionate, and that's actually probably quite valid. As with Sheard's criterion, Percival's criterion should be met, so that practitioners are encouraged by these authors to prescribe Prism that will actually make patients meet those criteria. Unfortunately, there's no evidence to suggest that this system does actually work, and hence you can see that it's actually quite difficult sometimes to make some decisions about exactly what the best prescription would be. So we often err on the side of caution, try exercises if at all possible, and then small amounts of Prism, and we wait until the patients come back and find out how successful that they have been. So you do have to take everything into consideration. So I hope you'll see that actually most orthoptic procedures in optometric practice are actually very easy to perform. Most tests are fairly straightforward, and the treatment methods, when you use them, can actually make a huge difference to your patients, but it doesn't have to be dead complicated and extremely difficult. So you can start with relatively straightforward situations and make a difference to your patient. All you need is your routine refraction equipment, and a page occluder is nice, not essential. A pen torch, Prism bar is absolutely brilliant, and decent fixation targets so that you can keep children interested if you need to. And so just to finish off, results that you'll get will be really good. Your patients will be very grateful, and you'll find that doing this type of work builds your practice. It makes a big difference to people. So you can do something that's relatively straightforward, doesn't cost too much money to get going, and that does some real good. Thank you for your attention.